Aesthetic results of dental implants in the maxillary anterior zone can be optimised using the labial glove and the subepithelial connective graft. With multiple case presentations to illustrate this technique, please welcome Shane to the podium.
I thought that was a very nice introduction. So, as long ago as 1967, we have Piotrkowski recording that buccal bone resorption is always going to take place, whether it's the maxilla or the macula. You'll also get crestal bone loss. Now, it doesn't matter what you do in terms of your implants, you are going to end up with something like this in the long term. So, with that in mind, if you then relate the edentulous sites to the dentate sites, you'll always see concavities, you'll see a movement of the mucogingival junction into a coronal position, and if there is any muscle attachment, you'll also see the migration of muscle attachment down into that edentulous site. When you come to the anterior maxilla, you'll also see that the frenal tissues will move into the edentulous site. Very difficult. Behind all of that, you'll also have a migration of the nasopalatine duct into the edentulous site, all disturbing the way in which you're going to do your implant. 3 years after you have an extraction, you can always expect such concavities to occur. The longer you wait with this, unfortunately, the results become much more extreme. Now, we are not really miracle workers, and in truth, when you get this sort of case, you're going to tell the patient it's going to be difficult to actually deal with it. We now have the idea that if you remove a tooth, you're going to have some wonderful suppressant effect on the buccal wall if you put your implant in straight away. Now, here we have Kosin, who is analysing both implant placements into an edentulous site and comparing it to a site where you're going to do type 1 implant placement. In other words, extraction, immediate placement. The idea being, by practitioners, that if they can get a type 1 placement, they're going to hinder the way in which that buccal wall is going to disappear. Not true. So, to reiterate what a type 1 placement means, you take out the teeth, you put in your implants. There are people who advocate don't do anything to socket void, it only requires a blood clot to occur, and you're going to get osseointegration taking place. What you see there is an edentulous site surrounded by what were dentate sites, and you can see that there was a depression, and you must expect that this depression is going to occur in those newly extracted sockets. So, you then have an idea, comes out in 2000, that you can hinder socket resorption by putting in some sort of xenograft. And the idea is, yeah, you've got a lot of bone disappearing, let's stick a lot of xenograft around there, and we're going to get a wonderful result out of it. Well, yes and no. What you got are confounding factors, and the confounding factors was that if you had abscesses, and the bigger the abscess, you had massive bone loss. And if you had a site like this, which had abscesses on it, and you put in your implants, your buccal wall is going to end up looking like that regardless of what else you do. To be noted here, you'll see that the nasopalatine canal has moved into the edentulous area. So, you have other confounding factors, periodontal disease, you've got not only a loss of buccal bone, you've got a loss of crestal bone. You have odd dehiscences, and it doesn't matter what you do here, you think you're going to do your external bone grafting and get a good result, you are really hoping for a lot. And it's better really just tell the patient that you're not going to be able to do it. Buccal bone fractures also will occur, buccal dehiscences will also occur, and you're going to have a problem. All of these have an inflammatory response that is continuing regardless of your type 1 placements. Also, when you're taking out such teeth, you get further fractures of that buccal plate. And these, we'll say, are guaranteed to give you a problem. So, we have amplified problems. And today, because we have our cone-beam CT, we can come along and analyse that buccal plate. And the buccal plate here, we can see, has got a fenestration. It's got very minimal bone, it's the coronal aspect, and you can expect bone resorption to go in this direction. Doesn't matter what you do, it's going to happen. So, with all that in mind, the presentation is going to have all 5 of those things. Labial gloves so that we can get continual uninterrupted vascularity for our healing effect. There will be simultaneous socket grafting to get rid of alveolar voids, and we'll have the placement of connective tissue graft, which is a full thickness connective tissue graft to include the periosteum for its attributes. We've talked about pocket lining, pedicle flap 2 years ago, and that's also going to be there. Specific suture techniques need to be used to actually do this. So here we have a classic case, very interesting internal resorption, which also takes away a lot of the buccal wall. We've taken out the tooth, we put a marginal incision, we preserve all of the papillae, we raise the flap, we've got our interesting crack in there through that buccal plate, prepare our osteotomy always over to the palatal aspect, and in that way maybe we will interfere with the displaying of that implant in the future. And there we can see it, it's placed in place, and into the void we are going to put our, first of all, before we place the void, we're going to put our connective tissue graft into the labial glove. In fact, it's placed underneath the labial glove and sutured so that it is not extruded from that glove. Socket preservation is carried out, socket hindrance is carried out, and you see a membrane over that, and the flap is replaced. The flap is replaced so that you don't get any sort of papillary compression occurring. You can also see at the cervical margin white, and that is specific suture material, and then 6 microrepeat so that you don't remove sutures. At the end of it all, so that we do not compress any of our bone grafting, soft tissue grafting, we fit adhesive ridges. That's what our implant looks like, and then 3 months later, that is what the site is looking like. When we want to come and expose, 6 months later, that's what we've got, and we can see that after the exposure we've got very nice compressed looking tissues, very thick tissues, and 3 weeks later we can come along and we can actually put our crown onto the implant. Now, that wasn't the end of the story, because we now get what's known as gingival rebound occurring, but what we've got, and you can see, is an interesting crestal bone morphology occurring, and 40 months later, post-crown fit, 47 months post-surgery, magnificent looking gingival margin, really mirroring the other side. That's where we came from. You can see that the crestal tissue is very well matured, and your width and keratinized gingiva is a mirror image of the other side. So, we know that you can actually hold the marginal tissues. You can actually put apically displaced marginal tissues back into place as well. And so, on a case like this, you've got the apical margin, the marginal tissues being displaced apically, but you've also got extremely thin bone at the buccal aspect of that tooth prior to extraction. So you must expect all of that to disappear and the depression to occur. Well, we're going to carry out the same sort of procedure. There is a labial glove, implants is there palatally, nice big void, And connective tissue is now going to be sewn to the inside surface of the flap, and after that it's going to be tucked high up into the sulcus. Following all of that, we will then put our xenograft into the alveolar void and cover it with membrane, and then sew it all back together. That is our result. And 6 months post-crown fit, that's where we're left. Yes, we have got a margin that is further coronal than the contralateral tooth, but that would mind the contralateral tooth is a crown. So that's what we get 14 months post-surgery. Quite a magnificent result. Same technique has been used throughout. So, going further, got a high lip line. We are showing stuff here. We know that we're going to take out the right hand tooth at some stage, but we can actually modify the gingival margin of the left central incisor. That's what we get at the end of our surgery. That's what we get when we are going to expose the implant, and 12 months post-crown fit, that's what we have. Magnificent with the keratinized gingiva. Absolute mirror image of the other side, and that is our radiograph at this stage, showing how mature our crystal ripples are. Another one, this is a case which maybe you want to avoid because it's got a peak papilla, young patient. We know we're going to have a lot of bone loss up there, and radiograph shows it. So, we're still going to do our same method. Underneath all of that, that is the sort of fenestration we've got, so we can expect to lose all of that bone. It's got to go. But, doesn't matter, go through with our technique exactly the same as before. And following all of that, we're going to see that at 6 months, we've got interesting looking set of tissues, been exposed, and that is our crown 3 weeks later. 18 months post-crown fit, that's what our tissues are looking like. Very nice looking crestal bone tissue. And 32 months post-op, that is our marginal tissue. Superb looking crestal bone. We now have the periodontally compromised. We know that we're going to have a massive inflammatory response in here. We've got lots of bone loss. We've lost at least 50% of the horizontal bone level. But it really doesn't matter. Same sort of incision is going to be carried out here. Implants are placed palatally, and now we will see that the granulation tissue from the pocket lining has been all preserved, because it is going to be utilized in our wound coverage. So up under there is our connective tissue, same method as before, and it's all sewn together. Temporary adhesive bridge is placed in over the top, protecting everything, no pressure onto those, extra pressure onto those tissues. And 3 weeks later, it's looking like that. I'll put this one in just to let you see what the palate looks like after 3 weeks. And 6 weeks afterwards, that's where we're at. Day of crown fit. Let's remember where we came from. And 18 months post-crown fit, 25 months post-surgery, that is our result. And that one is to compare to that particular site. So, that was the periodontally compromised. We now have an individually periodontally compromised. We can see that we've got a root fracture in here, and we've got a massive inflammatory response occurring. The inflammatory response will mean that we have up in there granulation tissue replacing the bone that you see there. And we are going to dissect that out. It's going to be used for our wound coverage at the end. And implant goes in, same as before, palatally displaced, just to show that we've got a massive amount of granulation tissue. And we are going to go and get our connective tissue, suture it underneath the flap. Socket is obturated with xenograft, covered with the membrane, and the pocket lining is placed over the top, and wound closure takes place. That's what our palate looks like at the end, and there is our temporary adhesive place, the bridge in place. Following all of that, that is for all of you to remember, because that's where all of the techniques come. 6 months later, for the exposure of this site, really to show how well developed and hard that tissue is. There is the crown on the top, very nice looking gingival margins. That's very nice crestal tissues occurring there, and that's where we started from. And 30 months later, that is the sort of result that we've got. And again, beautiful looking crystal tissues, and again, that's where we came from. Looking at CBCT, that's 30 months later, we can see that we've regenerated the bone. A case to be avoided, this is thin gum phenotype, regardless of the width of keratinized gingiva, massive amounts of recession. And we're still going to do the case. We've got a problem with the left-hand tip, and we've got further problems in that the palatal bone has disappeared. We've got thin bone at the front, and we've got a very patent, superficial nasopalatine canal. Doesn't matter, we're going to carry out our work. We know that because of that palatal bone loss, we've got lots of granulation tissue. It remains intact, attached to the palatal wall. There is our massive dehiscence. There is nothing there. Connective tissue sewn underneath the labial glove, and we now have the socket being obturated with xenograft, covered with the membrane, and then that's covered with the granulation tissue, and it's all going to be closed off. Temporary bridge is now going to go in place. Now, that's what we look like at 6 months. Very, very thick tissues occurring there. Very, very comparable cervical margin on both. Okay? Now, we know that you can change what was thin gum phenotype into thick gum phenotype. That's what was being utilised there. It's been around for a decade. You can use the same idea on a true periodontal problem case. You can, would say, guarantee that if you're going to replace those central incisors, you're going to end up with some recession that is going to be as aggravated as that. It doesn't matter what you do, unless you do what I'm showing you. And so, you've got further problems. Both of those central incisors suffered apsectomies. We have got a low buccal bone margin, and we've got an area of continual chronic infection, fibrosity, everything you can think of in there. And the other one, the left-hand side, has got no bone at all, and the tooth is sitting in gum. However, it is sitting in granulation tissue. It stays in place. So it is granulation tissue that we are going to utilise in this particular instance to accelerate, magnify our results. So that's what we've got. There's no buccal plate at all. Loads of granulation tissue, all left intact. Obturate all of the sockets with xenograft covered with membrane, and there's our connective tissue going right across both sides. You can see the pocket lining pedicle flap in its closure effect, and you get our temporary bridge over the top. And then 6 months later, that's the sort of result we've got, and we are going to put our crowns on. We can see very thick tissue there, and a few months later, that is the result of our work. So, what have we got? October the 15th, only 3 weeks ago, we have a systematic review, and it comes out with a set of information. Mid-buccal level of your cervical tissues and the interproximal gingival levels did not significantly change if you used immediate placement with a connective tissue graft. Width of keratinized gingiva significantly increased in this type 1 surgery with a connective tissue graft. Facial gingival thickness, gingival ridge dimensions increase following this sort of method. Very, very important. And it's only a coincidence God is on my side to actually show such a thing to prove my point. So for years we know that connective tissue graft is a volume enhancer. And you can come into a site like this and you can increase the volume. You don't have to put any bone graft in there, but people will put a bone graft. They think that they're being clever, or they want to believe that their bone graft works. So, labial glove again, in our normal mode, nothing is done to the buccal wall. It's actually fibrotic. There is no bone there at this stage. Okay? And if you actually expect that you're going to get revascularization to produce a bone graft substance, then you are really hoping for a lot. Connective tissue is taken, and it's going to go underneath the flap. Lovely big piece. That's all that's there is the volume enhancer. Again, suture technique, no compression is going to take place. I'll put this in because a few other implants we've done at the same time. And that's where we started from. That is our site. That is the implant a few months later. That's actually 3 months post-fit. And what you're going to have in mind, with that volume enhancing, there are a couple of special things that are going on, which are not really publicized very much in dentistry today. One is adipose tissue is in there, and adipose tissue is recognized today as the principal reservoir for stem cells in your body, just generally, and you've got pericytes. Pericytes because we have our periosteum, and pericytes are a multipotent stem cell. And so they are the ones that are producing our healing response at this site. Alright? Those are the bits of adipose tissue. Always used to trim them away in the past when you're doing period surgery because it gave too much bulk. But now it gives you a superb amount of bulk. So 58 months later, that's what we've got. There's no sense of any sort of concavity occurring in that marginal tissue. And when we look at the CBCT, we'll see that, well, actually, there is no bone at the facial aspect, the coronal aspect of that implant. Yes, there has been regeneration of bone further up the scale. So, still going on the fact that we've got volume enhancements occurring with the connective tissue. We are going to do type 1 implant placements on the left-hand side, and there's an old edentulous switch on the other side. So, right-hand side is getting connective tissue graft. No bone grafting is taking place. 24 months later, that is the sort of effect that you should expect from that connective tissue graft. Very, very complementary to the left-hand side. So, subepithelial connective tissue graft in implantology, thick biotype conceals your titanium, and you get a maintenance of gingival morphology, you get the ability to resist mucosal recession, and thick biotype itself resists recession. Going on from that, we now have the superperiodontally compromised patient, and well, nobody's going to do an implant here. I don't think anybody in here is going to do it. This one requires maximum surgery. Well, sort of. Here's our day of surgery, and actually, this is very long ago, and I've only put it in here to show you there really wasn't any bone. You've got massive amounts of granulation tissue, everything preserved. And we're going to work underneath that granulation tissue. Okay? And the implant's going to go in. We're going to obturate that site with our biowas, you might use biowas, and we're going to cover it. Alright? There is nothing. The only retention for this implant is actually in the apex. Cover it up as before. Now, the reason this is in here is that the work is still ongoing. This is at 8 months when I am exposing that implant. It's put in there as a picture to show what is actually underneath. Alright? Well, you've got an extremely large amount of bone in the process of regeneration. Implant is being exposed. That's where we came from. It's a magnificent result. Alright? That's where you came from. Nothing. So, you can go further and show what sort of techniques are going to be used for the same sort of things. Here is your labial glove. You've got little fractures occurring there. Implants up on the side. There's a bit of pocket lining pedicle at the back. We sew our connective tissue up underneath. And we use specific suture techniques to reappose the actual cut surfaces of the blade to stop any recession of the adjacent teeth. Okay? The technique is carried out on both sides, and that's what it looks like after 3 weeks. But in truth, you're not even going to take those sutures out after 3 weeks. You will wait 6 weeks to do it. So, you get another one, slightly different. We've got palatal wall fracture, so we've got lots of palatal granulation tissue, all going to be preserved, hanging there, implants up in place, and we're going to put in our bioarts into that alveolar void, and we're going to get in our connective tissue. We're going to be very happy with the results here, because not only have we got the volume enhancement, we've got this massive amount of pocket lining pedicle flap to close it off. We do not want to compress any of it because we are looking for bulk. Alright, so the suture technique is reapposition of that flap. That was a very beautiful little case, and we could see the volume. And that was my little presentation.